risk-benefit analysis and perhaps liaise with their oncologists. But if they've had their ovaries removed from the ovarian cancer point of view, yes, they can have estrogen.
Thank you.
Thank you very much. We'll move on to the next lecture.
Perfect.
Emily?
Thank you very much, Joanne. That was absolutely fantastic. So our next speaker is joining us in between theatre cases. So our next speaker is Neelam Potdar. So thank you so much for joining us, Neelam. So she is a consultant gynecologist and subspecialist in reproductive medicine and surgery in University Hospitals of Leicester NHS Trust, and she's been appointed since 2012. In addition to being reproductive medicine specialist and clinical lead for the fertility centre there, she also provides surgical treatment for complex endometriosis. She was one of the initial consultants who worked on obtaining the BSGE endometriosis centre accreditation in UHL. And Ms. Potdar does a lot of research. She's very active with various presentations and peer-reviewed publications. Her research interests include male infertility, endometriosis and early pregnancy. And she has been the co-chair for the RCOG Guidelines Committee and is currently a member of the NICE Women's Health Suites Committee. So we welcome her and her talk today on male factor infertility. Neelam, are you able to share your slides?
Do you want to do it at your end?
Yes, of course, I'll do it, no problem. Right, so can you see my slides?
Not yet.
We
Jay,
can.
You can? Jay, can you see my slides? Yes.
I can see Emily. Yeah. Yes, Neelam.
Okay.
Can you know?
Okay.
Neelam?
No, so sorry. I'm so sorry. Pre-lunch, we are having.
No, you're okay.
Problem. 2 seconds, please. I think I know what the trouble might be. Let me just troubleshoot. 2 seconds.
Do you want to try and share yourself?
Yeah, give me 1 second, please. Yeah.
Sure, I'll stop sharing, but I'm ready if you need me to. So yes, if you hit share and then window, if you've got your slides open. Hi, Neelam. Did you manage to get back in okay? Let's see.
Can you see me, Emily?
I can hear you. Do you want to try and share your slides or do you want me to try again?
I will try again if I can. 30 seconds.
So if you hit share and then hit window.
I've got the share and I've
Perfect. And then if you hit window, if you've got your slide open.
You know what's happening? I'm so sorry.
No, you're okay. Take your time.
I think it's because it's through the NHS net. Do you know the link?
Okay.
So
Maybe now we can share, and because you are in the
just
in the group.
See if you can share and I can see, please.
Perfect. Yeah. Can you see my slides, Neelam?
Yes, I can now. Thank you.
Perfect. So I'll start and then you just tell me when next.
Yeah, no problem. Thank you so much.
No, thank you.
Hi, everyone. Good afternoon, and so sorry for this. Firstly, I would like to thank the organizers, Mr. Abdul, Jay, and Emily, for kindly inviting me today for this symposium. And it seems an excellent symposium. It is the last talk of the morning, and hopefully it should be a little bit refreshing because it's on male fertility. And I will not take too much of your time. So please bear with me and you will have your lunch soon. I do want to please apologize to all the esteemed seniors in the meeting because I have tailored the talk a lot towards the trainees and those pursuing reproductive medicine and fertility. So a lot of it will be like something that you already know a lot. So without much further ado, Emily, please, could we go for the first slide? So the main objectives for today's talk is mainly to give an idea about what is male fertility, how much do we have it now in the current 2025, how do you approach it, and how important it is in terms of history and examination, and then what are the basic investigations, what does semen analysis mean to anyone, a little bit about azoospermia because it is important and it does throw out a lot of trainees in the clinic when they see first time azoospermia. It's like, oh, what am I supposed to do? So it's very important. And then just a quick review of the potential options that we can offer to these patients. Next, please. So history taking, so background. So what we have is, we all know that subfertility affects 1 in 6 couples or 1 in 7 couples. However, almost a third will have male factor subfertility along with other factors. And if you really look into it, 20% of the couples presenting with subfertility in our clinics are purely primarily male factor. So it is an important aspect and we have to look into it more. Assessment, most often when the couples come to the clinic, we do history taking, and often the male history taking is literally for less than 5 minutes. And we do talk about the semen analysis a fair bit. And then the next part comes is a lot of these patients would require further physical examination and further investigations depending upon their overall presentation. Next, please. So history taking. This is apparently one of the busiest slides of my presentation, and I do want everyone to spend a few minutes on this, because when it comes to having a conversation with the male partner, we have to know what their age is. And subsequently in the slide, slides in the presentation, I will show you why age is important. We do have to ask about how long they have been trying for. Have they had children in any current relationship or previous relationship? Important to ask about their general health, and that includes any medical conditions about diabetes, hypertension, and this also links to whether they're on any medications related to these conditions, because they are important. And the medications themselves could potentially have implications on their fertility health. Then questions about cancer, and it could be testicular cancer is one of the commonest cancer in the adolescent reproductive age group. So it is important to ask about it. So not necessarily you will say, but you will ask any illness and any history of any problems, and that will then reveal. Equally, any history of chemotherapy, radiotherapy, because sometimes what happens is the knee-jerk reaction is you've seen azoospermia, your mind is going, oh, what are we going to do? But when you carefully then take the history, you realize that actually this is expected and this is secondary to the treatment. And the options and what you do for them is completely different. So it is very important. The other one is sometimes, even though you ask any previous operations or surgery, and yeah, nothing major, because they're thinking about fertility. However, when you again prod around, you may come across that someone has had inguinal hernia repair, orchidopexy in childhood, and they've completely forgotten about it. So it is important to ask about these. And of course, any event involving the testes like trauma, torsion, mumps orchitis, all these can again have direct impact on the current fertility. Important to ask about timing and frequency of intercourse. What about the libido? Are there any erectile and ejaculatory problems? Now, these sometimes are not the easiest of the questions to ask. And I can definitely share because I work in almost our local population in Leicester, from the Leicestershire area. Fertility patients in the reproductive medicine clinics, we have about 55% ethnic minorities. So when you see these patients, it's not easy directly to ask. And it is, when they come as couples, sometimes they are more embarrassed than you asking them the questions. So you have to just find your way around. And there are ways of asking, and you will be surprised that quite a lot of men are actually happy that someone has approached this, because they're very hesitant to visit the GP for the problems. And when you ask them, then they're able to express as to what's happening. And again, it's kind of a linking together. So you have the ethnic minority, Asian population with diabetes, hypertension, and pretty much prevalent now in 30s and 40s. They then chronic diabetes leading to erectile dysfunction. So until and unless you ask these questions, you don't really get to know. And it might be, let me give you an example. The woman might be having endometriosis or severe vaginismus. The focus immediately when you start taking the history is, oh, we can't have intercourse, we've got problem. Okay, she's got vaginismus. You take the whole history and you're thinking, psychological, psychosexual counseling, dilators, what's the image, what are the things? Until and unless then you delve into, you will realize that actually both of them have issue. And equally, when you look at the semen analysis and parameters, so everything else need to be addressed. It is not just one aspect and what we can do with the assisted conception help. The other one is drug history. Similar to this, it is very interesting that until and unless you ask leading question about use of gym supplements and anabolic steroids, this is not something someone will just tell you conversationally. So it's important, and more so if you assess someone and you have the thing that maybe they're using, then you have to ask that just to confirm. And sometimes when they say we are using gym supplements, and I always ask, do you buy there, or are you buying and do you know that there are any synthetic steroids or testosterone in it? Because they might not be aware and they're using supplements that have got testosterone, and that will then inhibit spermatogenesis. Or it could be that you just need to, they might be knowing and you need to direct them. Interesting bet, and it is important in my opinion to ask. It is not just a checklist of do you smoke because of NHS funding, but it is important to ask about the smoking, alcohol, caffeine, use of weed, because that's again very common. Some people chew tobacco. Vaping is important because at the end of the day, these are chemicals, so we have to ask about them. And I will discuss briefly at the end, but to be honest, for pretty much of these lifestyle factors, which are associations, not the causations, you will find that there is plenty of research done to show and prove that they do affect the sperm health itself, sperm parameters, and fertility. And then it's about their vitamins, diet, supplement, which is important just to see whether preconceptionally people are taking and what they are. Occupation is interesting from two perspectives. Again, from male fertility, it is good to know what they do because this can have direct impact on the testicular function. So remember, everything is not just related to normal semen analysis, because when someone comes in the clinic, most often the GPs have done the work in the primary care for initial baseline semen analysis. You have a look, it's normal. The focus is, FSH is high or AMH is low, or there's hydrosalpinx on a scan. Your focus immediately goes there. What you have to remember is we are not just talking about the normal semen analysis and make a decision, but we are talking about sperm function, and a lot of these things can have an impact on it. So we are talking about traveling. So lorry driver, long distance drives for 12, 16 hours a day with hardly a break. And this is the profession, this is the daily lifestyle. You have to think into consideration exposure to chemicals, exposure to heat, pesticides, radiation, all these things are important. And to be honest, it will not be everyone on it. Even if it is a small percentage, it is an important aspect. So I would recommend actually, and when you actually take this history, it may take you a few more extra minutes. It doesn't take that long. So that would be my initial bit, that when we are starting with the process of having the first communication with the couple trying for pregnancy, these become the routine questions for the male partner. Next one, please. So coming to examination. So some of you are comfortable, others not so. In the examination, I would always say, please, BMI, checking the height and weight of the male partner is very important. Again, not just for NHS funding criteria. I think it is important because this itself has got implications on the sperm function, on the hormonal levels, on the sexual function. So it is important that this history, you know what the BMI is. The other one is testicle examination. So some of you who are not privy to this, so basically you can use an orchidometer, and as you see, normal testicular size would be between 12 to 25 mil. You could, in cases where you're examining the patients, definitely for those with severe oligospermia or no sperm, you can use the orchidometer to assess what is the testicular volume. And it is an indirect indicator which gives you an idea what is the likelihood of that testicular tissue functioning, the likelihood of spermatogenesis and obtaining sperm if you were to do further procedures. And along with it, you can check. I've had one occasion where I have picked up a testicular mass for further referral. So it is very important that at the same time when you are palpating the testes, you look for any obvious varicocele or any masses. Next one, please. And just to start on, for some of you, it is basic back to your medical school, but it is important because if you have this at the back of your mind, rest of the male fertility aspects in the tests and what we are doing just becomes easier, and it is easier to explain to the patients. So I would remind everyone that you have to remember that within the testicular tissue, you have the seminiferous tubules. And in these tubules, you have the cell, so your spermatogonia, that is going to go through the various cycles of cell division in order to become a mature sperm. And old textbook, this is almost 72 days cycle. And therefore, when we are talking to them about all these lifestyle factors, which are the associations which could impact, this bit is very important to know, because there is an opportunity, window of opportunity, even before you do any assisted conception treatment, to give them time to improve, and then subsequently the likelihood is that the sperm that you have at the time of treatment, there is a potential that the function might even be better. Next one, please. So looking at investigations. So the most common one, what we have is, of course, to assess is semen analysis. So this is how the sperm looks under the microscope. And you can see that they are moving sperm. You have the head and the tail for the sperm, and there is a neck of the sperm here. And these are all the important structures of a sperm in order to facilitate for the function of fertilizing an egg. Now, often when you see the report, and trainees will always say, okay, what is the conclusion? Because that's the easiest to read. However, there are about 10, 12 parameters, and what do you do with those? So yes, out of all those, the important ones, we do want to know, do they have sperm and what is their concentration or density? And this is usually in millions per mil of the sample. Then we are talking about their motility, and that is graded into various categories, whether they are moving, not moving, or they're very fast moving, or they're completely gone. And then the other one is, how do they look? Because you've got the head, neck, tail, there are millions of sperm. Do they look normal or there are variations? Next one, please. Just double click next. Thank you. So for those who are not aware, so how do these semen analysis parameters have come into play? So WHO has got literally a thick manual, which every 10 years it comes out to say, these are the normal ranges. This is how the sperm parameters should be. This is how the semen sample should be analyzed in a standardized way in all the labs. So everything is standardized. So we had previously in 2010 a manual, and now in 2021 new guidelines, slight variation, but pretty much you have your volume, you have the sperm number as the concentration, and this is in millions per ejaculate. Then total motility, so that's the total motile sperm and the immotile, but within motility, you do have the fast moving sperm, that's the progressive motility or the rapid motility, which is important for fertilization. So you have, previously it was 32, now it is 30%. And then important vitality staining is because out of all these sperm, you do want to know that at least a certain percentage of these sperm should be live. So this is where it is. It was 58%, now it is 54%. And the normal forms that out of all these, at least 4% should be normal. And this is just to give you that these are the parameters and this is how you would see. Next slide, please. Click again, please. So what we have is, when you get the report, everyone gets thrown out by these nomenclature. So these are old Latin nomenclature where zoospermia is your sperm, and we're talking about azo meaning no sperm, normal of course everyone interprets. Oligo means it's the concentration, it's the amount. So it is less than the standard lab reference range. And it's very easy, every single enrology lab, like your pathology lab, will have in brackets the normal range, and you can have a look with that. Then astheno is a bit lazy, that's my way of remembering. So that's your motility for the sperm. Terato is what we call teratogenesis. So that's morphology. So to simplify in your mind for remembering, that's an easy way to remember. You're looking for the normal number of percentage of the sperm. And then what you get is, sometimes you get these things in isolation, but more often you get a combination of one or the other. And when you look at the notes, sometimes you write this terminology oats. So it's not the oatmeal oat, but we're talking about oats. And that's basically saying a combination of all these together. Next one, please. So once we've done the semen analysis, we've got these results. In a small percentage, we would require then to do further testing. And these are the two scenarios where we call severe oligozoospermia, and that's saying the concentration is less than 5 million per mil. And sometimes we even decide, do we take it to less than 1 million per mil to do genetic testing locally in Leicester. And then we have the hormone profile. So we are looking at serum FSH-LH, testosterone, prolactin, TSH. Just a very gentle reminder, when you fill in these forms and ask them to do the test, please request for an early morning before 9 a.m. blood test for testosterone specifically. Of course, they'll have all the tests together in one blood shot. Importance is testosterone has cardinal variation, and towards the end of the day, actually the value is the lowest. So if you want to accurately know how the testicular cells are functioning, what is the concentration of testosterone, it is best to make sure that you advise for before 9 a.m. blood sample. Then comes the genetic screening. So genetics, we are looking at the normal karyotype. So females 46XX, males 46XY. So you do want to check. Reason being that one of the commonest conditions that we pick up with severe oligo or Klinefelter or azoospermia is Klinefelters, and they might be completely unaware, and when they go through the process of no conception, further investigations, that's when it is picked up. I've picked up a fair few, and their chromosome is 46XXY, so one extra, and or they could be the mosaic with Klinefelters, but it is important because if you pick it up, then you have to also think not just about whether the sperm is present or not and what next, but you have to think about the implications of a genetic condition on the diagnosis, on giving that report to them, what is the impact of it on them, on their long-term health, and also what is the impact of it on the potential offspring. So it is important that you do consider referring them to the appropriate colleagues, and that is why we all work together in ReproMed as, it's almost a multidisciplinary extended team, because then you've got your colleagues in endocrinology who will then look after their hormones and, testosterone and whatever else support they need. And then genetic counseling is, of course, integral part once you diagnose a condition. Cystic fibrosis, because cystic fibrosis is associated with absence of the vas deferens, congenital absence. Hence, it is important that the screening is done. And again, fair number of CF carriers or otherwise picked up via just the fertility clinic. Y chromosome deletion is important. We never used to do them before, but since we have started, since now there is more information about it and the genetic labs are able to do them, because it's important with the Y chromosome deletions because they've got ABC, and when they're doing micro-TZ with one of the deletions, you will not be able to get sperm, so there is no point in doing it. So it is important that we have looked at the Y chromosome, and until and unless you specifically ask, just asking for karyotype will not give you the information on Y chromosome deletion. And those of you who are doing rotations at UHL in Leicestershire, so we do have now, as you're all aware, we've got our central genetic hubs. So ours is East Midland, we've got the Nottingham lab, and we've got the one in Cambridge. So it is very important that the appropriate forms are filled in and the guidance is given for the appropriate tubes to be used, because lithium and the other one for your DNA. So you want to make sure that the phlebotomists know what tubes to give in. If you flip over to the form sent by Nottingham and from Cambridge, actually it is written behind the forms what specific tubes to be used for the specific tests. And lastly, sometimes if the prolactin is high, then you're thinking about pituitary tumors and you might need MRI. It's not very common, but it is potentially possible. Next one, please. So this is just another very important schematic diagram, which is very easy because we do for the females. So it's not difficult, but one has to always remember that hypothalamus in the brain is the starting point, and that's going to stimulate your pituitary gland to release FSH and LH. These will work on the two testicular cells in the testes, and LH will work on Leydig cells to produce the testosterone, which in conjunction with FSH will work on the Sertoli cells for spermatogenesis, and inhibin inhibits, and testosterone inhibits rest of the mechanism. So if you have external testosterone, it is basically giving a signal to the pituitary and hypothalamus. We don't need this PET. So it is very important that if you have this picture in mind, you are able to talk to your patients very confidently with the hormone results that you have, and you are able to organize the hormone results. Next slide, please. So it's not very complex. Let's take simple scenarios. If you have low FSH and LH and you have a low testosterone, what are you thinking? These both are low. So obviously hypothalamus and pituitary are not giving the signal, and hence your testosterone is not being produced. Okay? Hypogonadotrophic hypogonadism. Depending upon, I'm very much aware that every place works differently. If you have identified and you need to send to endocrinologists, do that. In our place in reproductive medicine, we look after these patients. I may still write to my colleagues, do you want anything more? Or quite often, they refer the patients to me with hypog needing fertility support. So either way, and then of course, treatment option for them is usually sperm induction for spermatogenesis, and it can take up to 9 months to 12 months. And it's one of the most effective treatments in terms of, they don't even need sometimes any further intervention, and spontaneous conception is there. And I'm not going to go at this point into funding and who does it and how. That's completely different. The next clinical scenario, you've got low FSH LH, but you've got high testosterone. Low FSH LH, testicular tissue is not functioning because there is no signal. Where is this high testosterone? Your high testosterone, sorry, it's number 3. High testosterone, where is it coming? And that is where then you have to make sure you again ask about the questions if they're taking any anabolic steroids. And sometimes they're being, to be honest, the patient is being truthful, you have to think laterally. That if someone is not taking and you suspect there is more testosterone and it doesn't answer your question with the testicular tissue, you have to think about the adrenal glands and the testicular tumors. Similarly, like in females, when we think, where is this extra hormone coming, cannot be explained by the hormonal profile. So very important. The other one is low FSH LH, and you have low testosterone, and you also then find that you have actually high prolactin. And this could be hyperprolactinemia. So then again, with hyperprolactinemia, everything else is being suppressed. And then you have to see that, is this hyperprolactinemia something unexplained, idiopathic, you need MRI? Or also you might want to ask questions about the medications, because some of these medications then lead to hyperprolactinemia. So it's in conjunction, but you need to do that. And sometimes treating that itself is going to then correct the whole spermatogenesis and sperm. And the last one is if you have high FSH LH. So if you've got high FSH LH and low testosterone, this is kind of not the most brilliant news, because then that's indicating that something is not working right, and that something means testicular cells. If you've got the pituitary continuously signaling the testicular tissue, please work harder, and still you're not having testosterone is on the lower side, you kind of know that this is either primary, secondary, basically testicular failure, the testicular tissue is not working really much. Now, one of the questions you all will have is, what do you mean by high and low? What are the levels? So when we are talking about hypog, we are talking about FSH LH 0.5, less than 1. And then similarly with testosterone, depending upon the lab range, less than 9 or less than 8, how low it is. Sometimes it is extremely low, and you wonder how the poor patient is actually managing himself, because the levels are so low that you think the energy levels and the drive to do anything must be so low, just because testosterone is so important for men. And then with the high FSH, this is very interesting, although there is now evidence that FSH on its own is not an indicator to determine whether you get sperm or not with micro-TZ procedures. However, it does give you an idea, and I have seen it that with the very high, if you're talking about like the female range, if you're talking about 20, 25, 30, you may occasionally get some sperm, but majority of the times, even with micro-TZ, there is a struggle around it. So you don't make a decision about not doing it. However, it is important because sometimes I think when right from the beginning, if you're able to guide the patients, their expectations are accordingly about the likelihood of getting sperm. Otherwise, suddenly they get false hope. And then it is too much to manage themselves when you then again say, oh, sorry, couldn't get this, couldn't do it. So you've got to be realistic with the patients, especially with what you have in front. And whilst I'm on this slide, I would like to again highlight with these hormone levels, there is another condition, which is normal FSH-LH, normal testosterone, and still no sperm. What is that? So testes are working, testosterone is normal, pituitary is normal, it's giving normal hormones. That's your cystic fibrosis. Or if they've had vasectomy or something, because that's like everything else is working, it's in the ejaculate, you're not getting the sperm, what is the reason? So that's how you think, and once you do it a few times, it's not that difficult even at a trainee level, but you just have to bear in mind that it's not about, oh, something is wrong with the sperm, it's just the same physiology, the same functions, we just need to dot our T's and I's to get the answer. Next one, please. So I have put this schematic diagram for semen analysis, and the reason for that is that it is very important to understand that when we talk about, because when you read a semen analysis, we are focusing on concentration, motility, it's all about the sperm. Or what you have to remember is that when you get the ejaculate, how is this ejaculate being formed? So yes, spermatogenesis is happening here. You will have the sperm in the epididymis. However, then it will have secretions from your prostate gland, from the seminal vesicles, and then ultimately you are getting the ejaculate from the urethra. So there are a lot of secretions, there are a lot of other glandular organs that are involved in getting what you get in a semen sample. So it is important, it is one of the semen analysis does give the most important information for us to decide for fertility and the functional status of the whole reproductive organ of the individual. And of course, the main concentration is here. So actually in the, that's the initial part, and then it gets diluted by all the other secretions. So it is a complex process when you look at it. So when next time you see a result of semen analysis and you're looking at the parameters, have a think about it, because sometimes you see white cell scenes, RBC scenes. So suddenly it is not that everything is coming out from the testicular tissue. There are other structures in between that could have some inflammation, acute or chronic, or there may be other reasons. Next one, please. No, it's the one before, please, Emily. Thank you. So it's the same one. The reason being that when you are, when we talked about the orchidometer and we talked about the size of the testes, it is important, it is well known that if you have a normal volume of the testicular tissue, that shows the spermatogenic capacity, and it is also linked with the morphology of the sperm, because then that means the normal amount is forming and your analysis will show better normal forms. The other important one is why I've kept this slide is to pay attention on when we are asking them about what medications you are on. And often I do get where the patient will tell me, Ms. Potdar, tell me, should I be on this med? I'm on statins. Should I be on it? My GP doesn't know. Okay, or I'm taking this medication for diabetes or hypertension. Does it affect, with my parameters? This is why it is important that when we are talking about the impact of all these medications that someone is on, and these are common health conditions, so it's not even like rare medications, then you have to see that transport of the sperm from the epididymis to the urethra, it depends upon these alpha-1 receptors in the smooth muscles of the vas. So obviously we are dependent. It's like almost analogy with the fallopian tubes, if that makes easier. So you are thinking that it's got to be transported. And that transport, that mechanism of the smooth muscle, one is obviously your, if you have absence, cystic fibrosis, or if you have vasectomy, but it's the motility. So if someone is on alpha blockers, antihypertensive medications, or someone is on SSRIs, how common it is, sertraline, fluoxetine, a lot of people for whatever reason, they might be on amitriptyline, backaches or spinal problems or something. All these will affect the function and hence the ejaculate. So it is important to ask these questions. And this picture I've just kept so that it just emphasizes that remember the normal anatomy and the function of the various organs involved. Next one, please. And then coming to just very quick slides on this WHO manual. So those of you who are really interested in knowing about it, I think although it is a thick manual, it is an amazing one. So you can pick and choose from the index what you want to read, when you want to read. But essentially speaking, the beauty of this was this manual and all the cutoffs are not, this is out of the fertile population. So about 3,500 fertile males over a decade. And these parameters have come that below all those that were fertile had this range. And then everything was out of range. So it is very important to know that this is within the normal fertile population that we have the ranges from. Next one, please. It's just an interesting fact. So the other question that you get asked nowadays from the patients, not necessarily we offer them, they will ask, what about, DNA fragmentation? Are you doing it? Should I be having it done? Or what about further genetic testing? So everything looks normal, but I've read on Instagram that, you could have these underlying, or you can have the whole genome sequencing. Do I need it? What do I need to do? And so on and so forth. There are so many tests that are available. Even now, further down, it's oxidative stress, and can you measure not just the fragmentation, can you measure what is your redox potential, what is the reactive oxygen species in the semen ejaculate, does it affect the sperm function, does it affect the embryo quality? Loads of answered to unanswered questions. These are still add-ons. Some of them have more information because in the last 10 years, a lot of research has been done. But this is in specialized setting. I would not say, oh, they're of no use, no point. What I say is everything is individualized, but that is at a much later stage when we have these discussions with the couple, but definitely not at the very starting point that you need to think about them. Next one, please.
Neelam, sorry to interrupt. Sorry, a couple of minutes, if that's okay.
Yeah, that's fine. It's very much towards the end now.
Yeah,
the last two slides, Jay. So yeah, this is all about the lifestyle factors, which we have discussed earlier on. And this is what you can do from the clinic. And then it's about obesity, which has got impact. And the other one is about the exposure to heat. So if you just do the next and next, please. So something to consider for all of you. There is more literature around impact of obesity, impact of male age. So if you just look, you can read the paper, But please bear in mind, if you look from 50 to 55 onwards, male age on its own has got impact on live birth rate and clinical pregnancy rates. So it is very important to guide the patients and see and not just look at the female age. Next one, please. So similarly, male obesity now has got a lot of research ongoing, and with the new GLP-1s and the impact. So it is not just about funding again, it has got obesity itself impacts the hormones, the testosterone, it impacts the function, sexual function, ejaculatory function, erectile dysfunction, and it has got epigenetics because it's going to impact the sperm function with DNA function. Next one, please. Azoospermia, majority of it I have covered in the previous talk, pretty much all of them. But once you diagnose, it's about in 1% of the men. Next one, please. What is important is we have surgical sperm retrieval procedures. You can either aspirate the sperm from the epididymis and or the testicular tissue, or you can do microTZ. So microTZ is pretty much taking the sperm from the spermatic tubules. Next one, please. This again, I have addressed that with your FSH, it does not make any difference. Next one, please. Lastly, just a couple of lines about microTZ. It is a commissioned service with NHSC, and they've got the guidance around it. And you're welcome to read this document. It's a very short document, but worthwhile reading. Next one, please. And they have just given a pathway, exactly what we have spoken about, how to assess someone. They have given exactly the same, that you should follow the pathway. And then, of course, this is at the level of when we are talking about assisted conception. You've addressed all the questions, and then you're planning that someone can have microTZ. So if sperm is obtained, they can then have intracytoplasmic sperm injection. Next one, please. And lastly, with the various aspects that we identify from the male fertility assessment, these are the options that either it is sperm induction, and that is fine, or most often we offer IVF with ICSI, where you help the sperm to get inside the egg for fertilization. Sometimes you will have sperm freezing, and along with all this, you have to make sure that you provide good support and counseling to the couple, to the male partner who has been diagnosed with where the problem lies, because sometimes it is very hard for them because they're not expecting that there would be any problem. And I think that's the pretty much last slide. Thank you so much. Thank you.
No, thank you very much,
I hope you get your
Neelam.
lunch.
No lunch today, Thank you very much for taking time from your theatre as well, and then coming and talking to us. Just a very quick question. What is your view on DNA fragmentation? Do you do in your practice?
Not as a routine, Jay, because even with the WHO, if you read the manual also, so there are multiple tests. And the bit about DNA fragmentation is it's not just about sperm. There are loads of body fluids where DNA fragmentation testing is done. And all the assays have different methodology, different ranges. And the question always comes right now, which comes to my mind, and I struggle with it, is yes, because they're not funded, they're all add-ons, people will pay for them. What do you do? What do? We ask them to be more on antioxidants and supplements and improve lifestyle, which
that you advise anyway, yeah.
And then they are having treatment. So I think it will be a very niche, small area where you're really struggling that you would offer.
Sure. No, that's fantastic. Thank you very much. Have a good afternoon in theatre.
Thank you.
If
thank you
possible,
so much
please
for
join.
Me. Thank you. Thank you all.
No.
Thank you for listening. Thank you.
And to the group, could we start at